Let's start today with the movements of small intestine. Like elsewhere in GIT, movements of small intestine are mixing movements, which are segmentation contraction, and propulsive movements in the form of peristalsis. However, this categorization is artificial because all movements of small intestine they cause some degree of both mixing and propulsion. Let's see how segmentation contractions arise. When a portion of small intestine distends with chyme, there is a stretching of intestinal wall, which results in localized concentric contractions at intervals along the intestine. Although these last for the fraction of a minute. But as one set of the contractions relaxes, a new set begins. And the new set, it occurs at new points between previous contractions. I have an interesting analogy here that segmentation contractions they divide the intestine into segments having appearance of a chain of sausages. These contractions are slight or absent between meals, but they become vigorous after the meal first enters the intestines. Segmentations are initiated by small intestinal pacemaker cells and they are mediated by enteric nervous system. Their frequency depend on the basic electrical rhythm, means the frequency of electrical slow waves. So in duodenum and proximal jejunum, normally maximum frequency is not greater than 12 per minute, while in terminal ileum it is 8 to 9 per minute. The factors which could affect these segmentations are distension of the intestine, hormones like gastrin, and extrinsic nerve activity. Segmentation contractions become weak when enteric nervous system is inhibited by atropine. This effect shows that segmentations are not effective without background excitation from myenteric nerve plexus. Function of segmentations is to chop the chyme 2 to 3 times per minute, mixing it with the excretions of small intestine. And also minor propulsion of the chyme, as these contractions they often travel 1 centimeter or so in the anal direction. Now the propulsive movements. You see, the chyme is propelled through the small intestine by peristaltic waves. This movement of chyme is very slow with an average of 1 centimeter per minute. It means that time required for the passage of chyme from pylorus to ileocecal valve it would be around 3 to 5 hours. And then these propulsive waves they rarely travel farther than 10 centimeter and they can occur in any part of small intestine. Of course, they move toward anus with a velocity of half a centimeter to 2 centimeter per minute. But they are faster in the proximal intestine and slower in the terminal intestine. Since propulsive movements are weak, they die after traveling 3 to 5 centimeter. So the net movement along small intestine is slow, only 1 centimeter per minute. Now, The control of these movements can be achieved through nervous and hormonal signals. Nervous signals for intestinal peristalsis, they are achieved through distension by beginning of entry of chyme in the duodenum, resulting in the stretch in duodenal wall. And then uh, there is a gastroenteric reflex. Uh, this gastroenteric reflex is initiated by distension of stomach, which spreads down along the wall of small intestine, and it is conducted mainly by myenteric plexus. The hormonal signals, they could be stimulatory or inhibitory, as they are shown here. Main functions performed by peristaltic waves in small intestine are progression of chyme towards the ileocecal valve, and also they spread out chyme along the intestinal mucosa. And this process intensifies as the additional chyme it enters the duodenum. Peristaltic rush. Now, what it is? It is it is the powerful and rapid peristalsis taking place in small intestine. You see, normally peristalsis in small intestine is weak, but the peristaltic rush, it travel long distances within minutes. And cause of this rush is usually intense irritation of the intestinal mucosa, such as in infectious diarrhea. This movement is initiated by the nervous reflexes that involve autonomic nervous system and brainstem, and also by the intrinsic enhancement of the myenteric reflexes within gut wall. So, what good this process does to the gut? It actually sweeps the contents of intestine to colon and relieves the small intestine of irritation and excessive distension. Well, another motility factor of small intestine are the movements caused by muscularis mucosae and muscle fibers of villi. These movements are initiated by local nervous reflexes in submucosal nerve plexus. And stimulant for this motility is again chyme in the small intestine. This additional motility is significant because muscularis mucosae, it can cause short folds to appear in the intestinal mucosa, which increase the surface area for increased absorption. Then the individual fibers from muscularis mucosae extend into the villi and cause them to contract intermittently, means shortening, elongating, and shortening again. So this causes the milking of villi, and lymph flows freely from villi to the lymphatic system. And then there is MMC. Remember, I mentioned the migrating motor complex once we started the motility chapter. It is an interdigestive motility pattern which serves as intestinal housekeeping. So let's look at this MMC. During fasting or between periods of digestion, the pattern of electrical and motor activity in gastrointestinal smooth muscle become modified. Cycles of this motor activity, named MMC, they migrate ab orally. When most of the meal has been absorbed, segmentation contractions cease and they are replaced by migrating motor complexes between meals. And they consist of organized but weak repetitive peristaltic wave that move a short distance down the intestine before dying out. Well, they begin in the stomach to the small intestine and migrate down at the rate of 5 centimeter per minute and at interval of 90 minutes, and they travel up to distal ileum. Here you can also see different phases of MMC. These MMCs, they are regulated by the hormone motilin. Circulating levels of this hormone increase at intervals of approximately 100 to 120 minutes, and they are coordinated with the contractile phases of MMC. Now, this motility is inhibited by ingestion of meal due to the suppression of motilin release. In addition, gastric excretion, bile flow, pancreatic excretion, and mucus discharge also increase during each MMC. Since MMCs sweep the remnants of preceding meal, excretions, also the mucosal debris and bacteria forward toward the colon. So we can say that they prepare the gut for the next meal. Well, so that was motility talk of small intestine. But before starting about large intestine, I have to mention some important structures. Now, food or chyme or whatever you call it, it has reached the ileocecal juncture. Now, it's a barrier between small and large intestine, which shows two structural features: a valve like action of the lower end of ileum and a ileocecal sphincter. Now, this valve, it protrudes into the lumen of cecum. It is forcefully closed when excess pressure builds up in the cecum and tries to push the cecal contents backwards against the valve lips. And it can resist the reverse pressure of 50 to 60 centimeters of water. On reaching the ileocecal valve, chyme is blocked for several hours until the person eats another meal, and that is called gastroileal reflex. Normally, about 1500 to 2000 milliliters of chyme is emptied into the cecum each day. So, I repeat again, a gastroileal reflex is when, after a meal, the peristalsis in the ileum pushes the chyme into the cecum of large intestine, where the valve, it has a functional significance of controlling the progression of chyme from ileum to cecum. Next is the ileocecal sphincter. It is formed by a thickened circular muscle in the wall of ileum. It extends for several centimeters immediately upstream from ileocecal valve. Normally, the sphincter, it remains mildly constricted to slow the emptying of ileal contents into cecum. Control of ileocecal sphincter is exerted by reflexes from the cecum due to the distension or the irritation of cecum. In case of distension, the contraction of sphincter is intensified and ileal peristalsis is inhibited to delay in emptying of chyme. This delayed emptying is also seen due to the irritation of cecum in case of an inflamed appendix. These reflexes for the control of ileocecal sphincter are mediated by myenteric plexus in the gut wall and extrinsic autonomic nerves by way of prevertebral sympathetic ganglia. How could we forget appendix? It is a thin tube about 4 inches long, sitting at junction of small and large intestine. Although the function of appendix is unknown, but there is a theory that the appendix acts as a storehouse for good bacteria, which reboot the digestive system after diarrheal illness. Now, moving on to colon, but first have a look which functions colon performs. Function of the proximal part of colon is the absorption of water and electrolyte from chyme to form solid feces, while the distal part of the colon serves for storage of fecal matter until it can be expelled. And for these functions, no intense movements of colon are required. So it means the movements of colon they are sluggish. Although the characteristics of these movements they are similar to those of small intestine, and it means they are same the mixing propulsive movements. The mixing movements here are called hostrations, and the propulsive movements they are in the form of mass movements. As I told you earlier, mixing movements occur in the same manner as segmentation movements of small intestine. But sometimes these movements constrict the lumen of the colon to occlusion even. Plus, both circular and the longitudinal muscle layer, they take part in these movements. You should know that the longitudinal layer of the smooth muscles in the colon that is arranged in the form of three bands or you can say strips and they are called tinea coli. Now, when large circular constrictions occur in which about 2.5 centimeter of the circular muscle contract simultaneously tinea coli also contract and in this way, the circular muscle layer and the longitudinal muscles they contract to cause unstimulated portion of the colon to bulge out into bag-like sacs, which are termed hostrations. Each hostration reaches peak intensity in about 30 seconds and then it disappears during next 60 seconds and new hostral contractions they occur in other nearby areas. Because of the mixing movements of colon, fecal material is dug into and rolled over since it is gradually exposed to the mucosal surface of the large intestine. Water and electrolytes they are gradually absorbed until the fecal mass is reduced to 80 to 200 milliliter per day. For this reason, forward propulsion of the fecal matter it is slow, especially in the cecum and in ascending colon. Well, these mass movements they occur only 1 to 3 times a day, and in many people especially occur after taking first meal of the day, the breakfast. Once the mass movement ceases, it returns about half a day later and usually force a mass of feces into rectum. Now keep in mind that a mass movement also is a modified type of peristalsis. Let me tell you now that how a mass movement is produced. See, a constrictive ring appears in response to distension or irritation, usually in the transverse colon. Then 20 or more centimeter of the colon distal to the constrictor ring, they lose hostrations and they contract as a single unit. So this propels the feces as a single unit in this segment further down the colon. Now, this contraction develops progressively more force for about 30 seconds, and relaxation occurs during next 2 to 3 minutes. And then another mass movement occurs farther along the colon, and this series of mass movement persists for 10 to 30 minutes. You might have noticed that a mass movement is initiated after meals. It is facilitated by gastrocolic and duodenocolic reflexes, which results from the distension of stomach and duodenum. These reflexes are mediated by extrinsic autonomic nerves to colon. As the mass movements, they force the fecal matter into the rectum, a desire for defecation occurs. However, normally neither rectum is filled nor there is any dribble of the fecal matter from anus. Most of the time, the rectum is empty of feces. So, how it is kept empty? Actually, a weak functional sphincter. It exists about 20 centimeter from anus at the juncture between sigmoid colon and rectum. And this sphincter resists filling of rectum. And also a sharp angulation is present at the juncture which provides additional resistance to filling. The next question is that how fecal dribble is prevented, and that is achieved by tonic constriction of internal and external anal sphincters. The internal sphincter is a several centimeter long thickening of the circular muscle lying immediately inside the anus. For the external anal sphincter, it is kept continuously constricted unless conscious signals inhibit it. This sphincter is composed of striated voluntary muscle. It not only surrounds the internal sphincter but also extends distal to it. Now, don't forget that external sphincter is controlled by pudendal nerve fibers, which are part of somatic system under voluntary, conscious, or subconscious control. Now here you can see a perfect flowchart for the defecation reflex, which is initiated when a mass movement forces the fecal matter into rectum. And keep in mind that this reflex has dual control over defecation, as there is a weak intrinsic defecation reflex and a strong parasympathetic reflex, both leading to defecation, but only under voluntary control. And in this figure, you can see these are the pathways of parasympathetic mechanism for, you can say, enhancing the defecation reflex. Okay. The defecation signals entering the spinal cord, they initiate some other effects also, like taking a deep breath, closure of glottis, and the contraction of abdominal wall muscles. Also, the pelvic floor that relax downward and pull outward on the anal ring to evaginate the feces. Defecation reflex can also purposely be activated. However, the reflexes initiated voluntarily are not as effective as natural reflex. So, how a reflex could be initiated? It is by taking a deep breath for the downward movement of diaphragm and by the forceful contraction of abdominal muscles to increase the intra-abdominal pressure. In case of lack of conscious control, defecation reflexes cause automatic emptying of bowel, as seen in newborns. Uh, this control is also lost in people with spinal cord transection because in this situation, the voluntary portion is blocked while the basic cord reflex is intact. So, the loss of voluntary contraction of external anal sphincter, it results in automatic defecation. There are some other reflexes also which affect the bowel activity. Peritoneointestinal reflex results from the irritation of peritoneum, and it strongly inhibits the excitatory enteric nerves, and it can cause even intestinal paralysis. Renointestinal and vesicointestinal reflexes, they are caused by kidney and bladder irritation respectively. And that's the end of today's lecture. Next time, we will look at the disorders affecting small and large bowel. Assalamu alaikum, students. Last time, I forgot to cover this topic, which is a part of a natural process. You see, the gastrointestinal gases which are accumulated in the gut or stomach or various parts of the GI tract, they are classified into two groups: exogenous gases, which get entry from outside, and endogenous gases that are produced in body. Now, 90% of the accumulated gases, they are exogenous, which enter the GI tract either by swallowing through mouth or drinking carbonated beverages. The rest 10% endogenous gases, they are produced by digestion of foodstuff and the interaction between bacteria and foodstuff in the intestine. The evacuation of the gases is achieved by these two processing: belching and flatulence. See, belching is a process by which the gas accumulated in stomach is expelled through mouth. Actually, the distension of stomach by the swallowed air, it causes this burping. Since distension causes abdominal discomfort, belching expels the air and relieves discomfort. And that's how most of the gas that is expelled through mouth and only a small amount enters the intestine. Act of belching requires coordination of several activities like the closure of larynx, which prevents entry of liquid or food with air from stomach into lungs. Also, there is elevation of larynx and relaxation of upper esophageal sphincter, which allows the exit of air through esophagus more easily. The other actions they include opening of a lower esophageal sphincter and descent of diaphragm. Now, this diaphragm movement it increases the abdominal pressure plus decreases the intrathoracic pressure. And all these actions combined, they cause expulsion of air. Flatus is the production of a mixture of intestinal gases and expulsion of flatus through anus under pressure that's called flatulence. As I already told you, the source of gases in intestine is the bacterial action on undigested sugars and polysaccharides, plus the digestion of some flatulence producing foodstuff, for example, cheese, yeast in the bread, oats, onions, beans, cabbage, even milk. Okay, so we covered this topic. Uh, as I told you in the last lecture, today we will start with the disorders of intestine. And the first one is ulcerative colitis. There is a strong hereditary tendency for susceptibility to ulcerative colitis. It's a disease in which extensive areas of large intestine walls become inflamed and ulcerated. Motility of the ulcerated colon often becomes so great that mass movements occur much of the day. And colon's secretions, they are greatly enhanced. So far, the cause for ulcerative colitis is unknown. It could be allergic or immune mediated destruction of colon wall and also could result from chronic bacterial infection. Now, the treatment options they include ileostomy and surgical removal of entire colon. Now, this disorder is rather common one. Gastrointestinal obstruction can occur along any point. Here is the list for different causes of obstruction of gut. But the consequences they depend on the site of obstruction, whether it is at pylorus, in small intestine, or in large intestine. If the obstruction is at pylorus, say due to fibrotic construction after the peptic ulceration, there will be persistent vomiting of stomach contents, which leads to depression of bodily nutrition, and excessive loss of hydrogen ion could also result in metabolic alkalosis. Now, let's say the obstruction is beyond stomach. In this case, antiperistaltic reflux starts from small intestine and intestinal juices flow backwards into stomach. These juices are vomited along with gastric secretions. So there is a loss of water and electrolytes, which results in dehydration, but with little change in acid base balance. If the obstruction is near a distal end of large intestine, feces would accumulate in colon and cause intense constipation. Severe vomiting leads to dehydration, which could worsen in circulatory shock, and sometimes a rupture of intestine is observed. Moving on to the next disorder, which sounds familiar, it is a slow passage of feces through the large intestine. Then it causes slight anorexia, abdominal discomfort, and distension that could be relieved only by the evacuation of rectum. It may complicate by causing inhibition of normal defecation reflexes, and it can result in vomiting and dehydration. Here is the list of causes of constipation, among which you may find some common reasons like low intake of fiber and inactivity, etc. Here, in this case, trauma to intestines causes a direct inhibition of the smooth muscles, which in turn causes decreased intestinal motility. Irritation of peritoneum also causes reflex inhibition due to increased discharge of noradrenergic fibers. So both the types of inhibition they cause the paralytic ileus, and due to the decreased peristalsis in small intestine, its contents they are not propelled into colon. Diarrhea is the frequent passage of unformed or liquid stools that results from rapid movement of fecal matter through large intestine. It can be acute or chronic. If it is of less than 2 weeks duration, it's known as acute diarrhea. 2 to 4 weeks duration makes it persistent diarrhea, and if it's more than 4 weeks, then chronic diarrhea. Severe diarrhea with or without vomiting results in dehydration, hypovolemia, circulatory shock, and electrolyte disturbances due to the loss in gastrointestinal secretions. Main cause of diarrhea is usually infections and ulcerative colitis. Antibiotics, fluids replacement, they are the mainstay of the management of diarrhea. Interestingly, diarrhea could be psychogenic also. Some of you might have experienced it also in last prof. Uh, Now, it accompanies the periods of nervous tension, like during examination time or when a soldier is about to go into battle. And it is caused by excessive stimulation of parasympathetic nervous system. As this stimulation, it excites the motility of colon and excess secretion of mucus in distal colon. These effects they combine to cause marked diarrhea. Now that you must get wholeheartedly. As your university question, vomiting is the mean by which upper gastrointestinal tract gets rid of its contents when any part becomes irritated or overdistended. And here is the list of causes. The usual stimulus is excessive distension or irritation of duodenum. Now keep in mind that vomiting is a reflex, and afferents of this reflex are vagi, both the vagus nerves and the sympathetic nerves. And the center lies near tractus solitarius of medulla. Now the efferent signals, they are carried by fifth, seventh, ninth, and 12th cranial nerve to the upper gastrointestinal tract, while the spinal nerves to the diaphragm and they supply abdominal muscles. When in early stages of irritation or distension, antiperistalsis begins to occur. It may begin as far as ileum at the rate of 2 to 3 centimeters per second, often many minutes before vomiting. So this pushes the intestinal contents back to stomach within 3 to 5 minutes. These intrinsic contractions occur in duodenum and stomach, along with partial relaxation of esophageal stomach sphincter. So the upper portions of a gastrointestinal tract, they become overly distended and they become exciting factor to vomiting. The mechanism of vomiting is intricate. You see, when antiperistalsis pushes the contents of upper part of small intestine to duodenum or stomach, obviously there is overdistension of duodenum and stomach. So take a deep breath, raise the hyoid bone and larynx. Next, upper esophageal sphincter is relaxed, along with the closure of glottis, while the soft palate is lifted to close the posterior nares. Simultaneously, you experience contraction of abdominal muscles and lowering of diaphragm. And on relaxation of lower esophageal sphincter, the gastrointestinal contents they are ejected through esophagus. Now, one important thing you might have noticed is chemoreceptor trigger zone. You see, aside from irritative stimuli in the gastrointestinal tract, vomiting can also be caused by nervous signals arising in certain areas of brain. One such particular area is called chemoreceptor trigger zone for vomiting, and it is located in brain's medulla, precisely in the area postrema, on lateral walls of fourth ventricle. It is responsible for initiation of vomiting by its direct stimulation through maybe through certain drugs like morphine, apomorphine, or some digitalis derivatives, or it can also be stimulated through motion sickness, because motion sickness also manipulates this CTZ. So, as we are talking about motion sickness, in this situation, a rapidly changing direction or the rhythm of the motion of body, it can cause vomiting. Wonder how? You see, a motion stimulates the receptors in the vestibular labyrinth in inner ear. These impulses are then transmitted to the vestibular nuclei of brainstem, and from there, not only to the cerebellum but also to the chemoreceptor trigger zone, and that's how rapidly changing motion it could result into vomiting. Does that also sound familiar? Nausea is a conscious recognition of the subconscious excitation in an area of medulla in close association with or a part of vomiting center. Usually, this sensation is a prodrome of vomiting, but only certain portions of the vomiting center they are associated with nausea, as indicated by occasional vomiting without nausea. So, here is the list of certain impulses which cause nausea, and you can see that they not only mention the usual stimuli but they also explain that why certain situations, thoughts, or even certain personalities they could be nauseating. Dysentery is one hell of a nasty disorder in which acute inflammation of large intestine is characterized by frequent loose stools mixed with blood and mucus, and this could become fatal also. Malabsorption by small intestinal mucosa, that is called sprue, and it could be tropical or non-tropical, two types of the sprue. However, the consequences of malabsorption, they are not simply the nutritional deficiency and the macrocytic anemia, but they also include steatorrhea, osteomalacia, and even inadequate blood coagulation.